My name is Rashmi Halker Singh, and I'm the deputy editor of Headache. I'm joined today by Dr. Kate Bedrin, who's one of the authors of a recent publication entitled Raynaud's Phenomenon Associated with Calcitonin Gene Related Peptide Receptor Antagonist Case Report. Welcome.
Thank you for having me.
So I was really interested in your manuscript for several reasons, of course. Can you begin by telling us about the cases?
Yes, so we have two cases in our report. And in both cases, someone's using an oral small molecule CGRP receptor antagonist, and there seems to be some association with Raynaud's phenomenon. Our first case, she was using rimegepant as needed. And initially, it was actually the best treatment we found for her. She had been using onabotulinum toxin A for her preventive, but we couldn't find an acute treatment because she was very prone to side effects. So when we got to rimegepant, she absolutely loved it and used it for a few months. And then all of a sudden, she said she had an episode following taking it where her hand went blue, cold, and was so painful that she actually went to the emergency room. They didn't know what it was, didn't think it was anything too scary, so they sent her home. At this point, she never told us about it, so she continued to take her rimegepant. And I think around 2 months later, it happened again. And this time it was involving her hand and her heel. And it was just as painful. It turned blue. And she came in to see us shortly thereafter and was like, do you think they could be related to my rimegepant? Because it's the only medicine I took within the time frame. Her history was she had never had a history of Raynaud's phenomenon before. Her sister did, but she never had it herself. She was not a smoker, no other secondary causes we could find. So we instructed her to stop the rimegepant, but she was obviously very sad because it was the only thing that ever worked for her. So he said, maybe you can try ubrogepant. She had used it once before and got sedation at 50 milligrams. So we said, cut it in half and see if 25 milligram would work just as well, but without the sedation. This time around, when she took the ubrogepant, just 25 milligrams, she had the same symptom where her hand went blue, painful, and lasted for a few hours. So we said at that point to stop the medication. We did a workup for secondary causes, didn't find any. And so we told her just to hold off on taking it, and she didn't have any further episodes. So in that case, we thought there was some association possibly.
And in this case, the episodes happened time-wise soon after she took her dose
This
of
is the
Vijaypant,
other,
right?
it's a little bit longer than you would expect for the half-life of rimegepant. I believe the first episode happened almost 30 hours after, and the second was similar, maybe more than 24 hours. So in the same way, we thought it could be due to chance because the timeline is a little bit later than we would think. The ubrogepant did happen quickly after, but the two incidences with rimegepant happened a little longer than we would have expected. But once we told her to stop the medicine, it didn't happen again.
That probably added to a little bit of the confusion of what was going on as well,
Yes.
because it wasn't so close in temporal relationship to taking the medication.
And sometimes she would take it and not have that experience initially,
Oh,
at least.
okay. So
And then
that
our
was the first
second
case.
case,
Yeah.
yes. And then the second case, we had a patient actually using atogepant off label for chronic migraine. And she had been taking it daily. And I think around 6 or 7 weeks into the medication, she had an episode, she said, where she was angry with one of her children. She was clenching her fist. And the next thing she noticed, it turned a different color, was painful. And that lasted for a good minutes to an hour for her. She didn't think much of it. And then a few days later went to get blood drawn and had a tourniquet around her arm. And the same type of sensation happened where she had the discoloration and the painful sensation. So she was also instructed to stop the atogepant, and she did not have any symptoms of this following a cessation of the atogepant.
Yeah, that's really interesting. There have been, as you know, because you wrote about it, there have been some instances of similar situations happening to people on the CGRP monoclonal antibody
Yes.
medications as well. Given that information and given your experience with your patients here, do you think we should be screening for the presence of Raynaud's before we initiate, a CGRP affecting medication like a monoclonal antibody or a GPANT?
Initially, it was never something that I did in my practice. And then we saw these few cases, and I had heard other patients now looking back that actually reported symptoms similar, but it was before we had a lot of this information. So I've been slowly over time asking more and more patients before I initiate it. It doesn't stop me from initiating the medication, but it lets me warn them what to look out for if they do have the symptoms so that they can then tell me. Because in my first case, the patient went to the emergency room, no one knew what it was, and then it went on for another few months before she ever brought it to my attention. So for those patients, I'd want them to just consider it if they've had a history of Raynaud's phenomenon before. And so for some patients, I'm starting to screen more and more. And it's interesting because migraine and Raynaud's phenomenon are common with one another. So we actually, when I ask, many patients don't list it on their problem list, but I say, oh, yes, I have that. So it's something to tell them possibly it could worsen your symptoms and just look out for it while you're on the medication. So I'm starting to screen. It doesn't tell me not to use the medicines, but at least lets me warn the patient and then put it in my notes so I can follow up at the next visit to see if it is a symptom that's worsening for them.
I think that's really good advice, especially given that at least with one of your patients, there was no Raynaud's to begin with, and it was something that
Yeah.
developed with use of the or we're assuming after use of the
Yes.
medication. Anyway, so screening probably would not have been helpful, but counseling the patient to look out for this possibility would have been if we had thought about it.
Mhm.
Um, any other ways that this has impact your care of patients?
So, for some of my patients, even if they've never experienced Raynaud's phenomenon before, or they did and they've noticed slight worsening with either CGRP monoclonal antibody or GPANT, they don't look very happy when I say, maybe we should stop it. So sometimes we discuss maybe taking precautions to prevent it. We're in DC, so now it's cold. So I'll say, you should always be wearing gloves, warm socks, keeping your digits warm. And so sometimes we'll try that intervention first. And that's even what we were trying to do with my patient in case one initially, because she really did not want to stop it. And so I found a few people who just thought that their Raynaud's had worsened with one of these treatments. Sometimes already had some tricks that they would use because their fingers and digits would get cold. So I encourage them to try to be more preventive with it and don't let it get to that point. So that's one thing we do in our practice. And then the other is for some patients, especially my patient in case one, she really wanted to try a monoclonal antibody after all of this. And so we had a discussion and she understood the risk. And so we did end up putting her on erenumab. And she now had like days long of her leg feeling cold to touch. And so it's something you should discuss with your patients. We then, of course, stopped all of these agents in her and said, unfortunately, although you respond to them, we just don't think you can tolerate them. But it's something that I think is important to discuss with your patients because they really like these treatments sometimes. And so to try to get them to stop it is a negotiation to see how we could maybe enable them to stay on it. And then for a few of them, unfortunately, we'll have to say, I think we need to stop now.
Well, I think that's great advice. Just like you, I'm a clinician who sees adults who live with migraine, and I mean, just today I've seen several people who are on monoclonal antibodies and GPANs, and I think this will impact how I address this conversation too. So that's really helpful. Thank you for that.
Of course.
Do you have any final thoughts?
I think the final thoughts are just more research is needed with these treatments because we know CGRP is involved in many systems throughout the body. So I think as they've been out more in real world data is showing there are some other off target adverse effects possibly. So it just opened our eyes to there's some things we didn't consider initially when we were prescribing them. And then now the dual combination of the monoclonal antibody with the GPANT, I think more research is needed to know kind of what happens with this dual blockade in these types of patients. Neither of our patients were on dual blockade, but what would have happened if we did have them on it?
Those are excellent observations. Well, thank you for these case reports. I think they will
Of
definitely
course.
impact patient care. And I think you being so astute and caring about your patients has translated to helping not only those individuals, but likely many more. So we appreciate that as well.
Thank you.
Thank you so much for speaking with me today.
Thanks.